hand when he sprayed it into his hand. And um, and so he started using that. He started doing cryoablations. He started essentially, he worked with Reynolds to create a catheter that could be inserted in the brain, and the tip could be cooled, and it could be cooled enough that it killed the cells. And surgeries like that are still being done, and it is actually the preamble. You guys may have heard of focused ultrasound. If people heard about that procedure for tremor, it's a preamble to that being done today. So we'll talk more about that. Uh, Around that same time, this pair, the neurologist and neurosurgeon pair called Spiegel and Weichs, started doing stereotactic surgery. They had this very comfortable frame that you would apply to the head, and they put probes and make these very focal lesions to control tremor. And what's remarkable to me is that this is really, this seems like 1,000 years ago. It's not that long ago. This gentleman, Phil Gildenberg, was sort of one of the presidents of our society. He was there. He was a student in their lab during the time that they were doing the first of these surgeries. And so it really is in one person's lifetime. He just passed away. He was sort of he'd written the major textbook in our field, and it just passed away last year or 2 years ago. Um, so all of this has been done in one lifetime. Um, what's remarkable is how they were doing this when there really was very little knowledge. I'm fond of showing sort of, some of the scientists and surgeons that we have in the room. 5 years after those first surgeries were done was this very seminal paper by Hodgkin and Huxley where they described how neurons work. Like, we didn't know, even when they were doing the surgery, that there were action potentials and the things that we now take for granted in the way that neurons work. We really had no idea. And so they were figuring this out and actually doing interventions at a time when really our understanding was very minimal. Today, we know much, much, much more. And I'm going to try to take you all the way through from where they were then to some of the very advanced techniques that we're using. Have I bored anyone to death yet? Are you guys doing okay? How about in the audience? Are you guys hanging in there? Um, so I'll describe briefly how we think this works. So we've talked about the basal ganglia and why burning holes in it might work. So every medical student is sort of tortured by having to learn this wiring diagram. Maybe the lights, it doesn't show up as well. But this is kind of, there are a handful of nuclei in the basal ganglia that are all interconnected. And they are all fed by this, because I've heard of the substantia nigra that we lose cells in during Parkinson's disease. And that sort of spritzes dopamine onto this whole circuit. When you lose that, you lose the dopamine, it alters the way this circuit fires. And parts of that circuit, and this is still sort of hotly debated, what happens to that circuit? There are areas that fire more. So in the STN and the GPI, those are key areas that seem to fire more. They also seem to fire irregularly. They fire in rhythm, which they shouldn't do. They should be firing sort of at a nice, smooth, even pace. And it's something like, the best I can describe is if you've ever had your washing machine and you put too many clothes in and it's sort of unbalanced and the thing starts to kind of shake. It has an irregular rhythm like that seems to cause trouble, causes tremor, slows down the system, etc. And so we've become to understand that beta rhythm, as it's called, can be really problematic. For whatever reason, we didn't first understand that. It began to suggest targets. First, the GPI, which is the area that was ablated by pinching off that vessel, the STN, the thalamus. These have all become targets that for decades we have been putting probes in those targets and burning those cells, and it's enough to sort of stop that hyperactivity or that regular firing that causes trouble. And still, we sometimes do that today. And that was pretty much the state of the field. A lot of that was done in the 60s and 70s. Come to the 80s, and this gentleman, Dr. Alim Benabid in France, had this particular day, and it's interesting how I don't want to give people the impression that accidents happen all the time in surgery, but they do happen occasionally. And when you have someone really smart who's doing it, like Irving Cooper or Alim Benabid, they discover something from it. So he had a particular day where he was using a stimulator. He was getting ready to burn some of these cells in one of these surgeries, and he was using a stimulator that we will frequently use at a low frequency, just to make sure that we're not near some pathway that is going to cause trouble. And someone had left that thing dialed up. Instead of being at 20 hertz, it was dialed up to like 150 hertz. And he turned it on, and they didn't get the side effect they were looking for, but the tremor just went away. And he had the foresight to say, well, hold on, what just happened there? And they turned it on again, And sure enough, the tremor went reliably away. And he started to think, well, gee, is there some way, he knew he was actually has a PhD in physics as well as being a neurosurgeon. And he said, well, isn't there some way that, we could use this? And so he started to think about putting electrodes in the brain and using high frequency stimulation chronically to control tremor and control other things. And so that really is the beginning of DB. There was some stimulation done before, but he's really the person who figured it out and then popularized it. It was about 20 years from that first experiment in the 80s until it became FDA approved around 2000 in the US. And so I'll show you one of his videos. And there is narration. I'll just sort of narrate it. It's a little simpler. So these are old videos. Well, let me turn it off here. I'll just describe it. So this is a gentleman. Hopefully you can see. It's grainy video because this was done in the 1990s, I think. You can see here he has classic Parkinson's disease. He's not on medication. He's very stiff. He needs assistance to get up. It's challenging for him to walk. He is a patient that does not have a lot of tremor, and some patients with Parkinson's don't have a lot of tremor. It's only one of the features, and it's variable. So here he is sometime later. This is the second segment, and you can see here he's actually had the surgery, but they've not turned the system on yet. So they're making the point that the surgery itself doesn't really have any effect. It's not like the lesion surgeries that they were previously doing. And then you'll see, and I'm sorry, the video is a little dark. So still very frozen, still having some trouble walking. And here they're turning it on, and you can see at that time they needed like this whole suitcase of electronics to do it. Today, that's essentially an iPhone or iPad that does it. And you can see instantaneously how his hand speeds up. He's suddenly able to move. In just a few seconds, and then you can see here. Yeah, and I think you can see even on the video that his face is also more expressive. In Parkinson's disease, we also have this sort of flattened face. He's smiling. He's able to do this. I think they're asking him to do that. He's not just dancing or something. But really a pretty impressive effect. And so this was recognized as a significant innovation, and it has the advantages that with the lesion, once you do it, you're kind of stuck. If it's enough, that's great. If it's not enough or too much, that's a problem. Here you have the ability to adjust it, and that has been helpful. Okay. Any questions about that? That's kind of the preamble. Yeah. We do, exactly, yeah. So the brain is crossed. So when we stimulate the left side of the brain, it helps the right hand, and vice versa. In most patients with Parkinson's disease, by the time they are severe enough to want surgery, to merit surgery, usually it's bilateral. And so most of the time with Parkinson's, we are doing a bilateral surgery. But there are some patients who have what we call hemi-Parkinsonism, where it really just affects one side. And in those patients, it is perfectly reasonable just to do the opposite side. If your right hand has tremor, your right hand is stiff, doing the left brain is probably the right operation. There are some centers, the other thing people debate in the field is, should you do it all at once? Should you do both sides in a day, or should you do one side and wait a while? And so University of Florida in particular, which is a very prominent center, tends to do one side and then wait months for the other. And some patients will get benefit from just one side. We'll sort of, even though they have bilateral symptoms, we'll get so much better from just the left side being turned on that they say, gee, my right hand's great and my left hand's enough better that I don't want the other side. And so some percentage of those patients decide that one's good enough. Here we, for the most part, will do two sides together unless there's a good reason, unless we think that the patient, that's just too long a day, the patient probably only needs one side, or we need to stage it to do one side and then wait a few weeks and do the other. It's basically the same surgery twice. Yeah, they both run to the same battery, so there are parts of it that are that we do together, but the main day of surgery, and I'll describe all the stages of surgery. The main day of surgery is putting this electrode in the brain, and For most patients, I say we do it together. For some patients, we do one side, wait a week to the other side. And most of that is because it takes, and I'll describe, and we can actually discuss this. We do the surgery awake. Some centers are starting to do that with the patient asleep. We can do that. I've done that for some patients who just say, gee, I just can't imagine being awake. But for the most part, we still think there is an advantage to being awake in the surgery because we really can see the effect. We see the tremor go away. We see when there are side effects, and we use that to guide the placement of the electrode, to move it a millimeter this way or that way. And we think that really does improve the way that stimulation is done. I think it's more precise. Every year I ask myself, okay, if I were having the surgery tomorrow, would I want to be awake or asleep? Every year it gets, our MRIs get better, our targeting gets better, our stimulators get better. And every year I think to myself, okay, is this a year that I should just do them all asleep and not worry about making the patient, be awake through it? Because it's sort of like a day at the dentist. It's not terrible, but it's also not that much fun. To date, I still feel like there's a big enough advantage that I would want it awake if I were going to have it. And so I usually recommend that to patients. If someone feels strongly, I'm very happy to do it asleep. And we have all the things that we have intraoperative CTs and things that can help us confirm that location and still get it, pretty close to right, I think. So the batteries last on average about 5 years. Shall I just repeat? Yeah. Okay. So the question was how long do batteries last, and I'll get into some of that. Also, most batteries that we use today are what we call primary cell. They're just a regular battery. You don't have to recharge. Those last on average about 5 years. They are improving a little bit every year. We now have 3 companies making this, which has been great for the field because they're competing with each other and they're making better devices every couple of years. There are also rechargeable batteries. Those last up to like 15 years, but you have to charge it once a week. Some patients want that. We don't recommend. I tend to recommend that in patients for whom the first battery has run down really quickly. There are some people who need kind of higher voltage, and if we're doing that, then when we replace it, we sometimes go to a recharger. All right. So I'm going to talk about stereotaxis. Does that word mean anything to anybody? Probably not. Okay, so stereotaxis is this idea we've got to get to a little spot right in the center of the brain, and we need to do that with great precision. So stereotaxis was this technique that was developed in the 1800s, where you have something that is fixated to the skull on the outside of the skull at points that we recognize and we know, and then we can use that to identify points inside the skull because we have some kind of imaging. We have an MRI. We can see the distance between the points on the outside of the skull and the inside of the skull, and we can use this kind of a caliper system to put a probe into the brain. So this was actually the first one that was ever described as in 1889. There was not a lot of surgery being done at that time. Around that time, this gentleman, Victor Horsley, created what was kind of regarded as the basis for the frames we use today. He had a fantastic mustache. He's very famous for that also. But in addition, he invented this thing. It was never really used in humans. This device was used in animals. That surgery that I showed you before with Spiegel and Weichs was an adaptation of that frame. So they had this kind of uncomfortable thing that was, plaster cast put on the head and a frame that had, you have basically millimeter measurements here, so you can measure where you're going and you know where that is in the brain. And then, what's really remarkable to me is that was sort of modified within just a couple of years by a gentleman by the name of Lars Lexell in Sweden, who created the Lexell frame. The Lexell frame is an adaptation of that frame. He did this beautiful thing where he combined a Cartesian coordinate system and a polar coordinate system. And the combination of those two makes a very flexible, safe device. Who's had DBS surgery? Do we have one person in there? Okay. Do you mind if I ask you a question? Did you have anything like? What's that? No. Oh. Okay, I appreciate it. So did you have one of these frames? Most centers still use the Lexell. Look like that. Okay. Mm-hmm. Got it. Yeah, and. Mm-hmm. Yeah. Yeah. Okay. So for those in the audience, he's describing sort of the standard Halo frame, and they're basically two. There are two brands. One is still the Lexel frame, which is yeah. Yeah. Okay. Okay. To do the testing. Yeah, that's pretty typical.
That was the best part.
Mm-hmm.
That was when the central trigger was the best control.
Okay.
After that, it has been a crash.
Huh. Okay.
Here.
Got it. Okay. We'll
There's got to be a better place.
be happy to talk about it. Absolutely.
Bring me to it
Sure.
right now.
Okay. But in the OR, you had a good response. It worked well. Okay. 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 Yeah. Question in back. Okay. Yes. Most do. I mean, we give them sedation during the uncomfortable parts, and I'll show you the frame we use, which is not this frame, which is a more comfortable frame. Good. Okay. Good. Okay. Sure. Okay. All right. Well, so let me go ahead. I'll walk you through all this, and I'm happy to answer, all the individual questions and others. So, I mean, this for the field, and again, this came about around the 1950s. This was a huge change in the field. Suddenly, we could do all kinds of things that we could not do before. We were able to put probes and create lesions and treat diseases that could not be treated previously. And so, this is one of the first precedents. So, there's a society called the World Society for Stereotactic and Functional Neurosurgery. This was one of the first presidents of it. I'm today the president of the American Society for Stereotactic and Functional Neurosurgery, which is related to that. I consider myself sort of part of this lineage, and this was really the beginning of that society. They created a society, because they were trying to figure this out. How do we treat things in the brain, and what do we have to do that more effectively? And these people started to talk to each other. So it was an exciting time, and I think remains a very exciting time for helping people through neurosurgery. Something that's interesting. So when they were doing these first surgeries, we didn't have MRIs, we didn't even have CTs. What we had were X-rays. And so this is when they were doing those surgeries, and remarkably, we're doing them effectively. This is a picture. You can kind of make out that there's a skull here, and inside the skull, these are the ventricles. They've put dye into the pockets of fluid that are in the brain, and that's all they had to do the surgery, and they were able to figure it out just from that. Today, remarkably, and it's too bad this doesn't show up. If you could see it on my computer, we have beautiful imaging. We can see every detail. If the lights were down, you can see every blood vessel, you can see every subnucleus. I can see the GPI very clearly right here. It really makes, we have it a whole lot easier than those surgeons did. And I think that's making the surgery better and better. Although these are just more pictures, but I'll move through these. I think that's probably not as helpful as some of the other stuff. Here you can see where some of these targets are, but again, if you're not doing the surgery, it's probably not. I'm going to move through this quickly. So here are some of the techniques. So I talked about the frames that we use. So there are different ways to do the surgery, and I'll show you some of these. So this is sort of that traditional frame. This is actually today's Lexel frame. It's just a little bit different than the one that they had. There's another version called the CRW frame, which is more similar than different. People have adapted that to make robotic surgery. So they have robots that essentially do the same thing. They dial in those coordinates with this arm, and they have the same accuracy. This is the frame we use called the micro platform or StarFix frame. That frame has some advantages. It's a 3D printed frame. So for every patient, we put little screws in the head, we get a CAT scan, and then we tell the computer, okay, here's where I'd like to put the target. Here's where I think the trajectory should be. I make sure I know where the blood vessels are and avoid those and do all these things safely. And then it prints a customized frame that looks something like that. And we take that on the day of surgery and we just attach it to the head. Patients then can still move their head during surgery. They're not bolted to the OR table the same way. And so it makes it a little bit easier, a little more comfortable. There are other ways of doing it. There are people doing this with an intra-MRI technique. So here you can see a patient who was asleep in an MRI, and using this device that fits on the head, they can kind of see where they're putting it in real time. That has some advantages. They can see where they're putting it. At the same time, they can't see the effect. And we know that even moving a millimeter, if you're in the STN target, the target that we want, being in the front part by 1 millimeter may be different than being in the back part, and you really can't see that effect. So for that reason, I have not adopted it, because I still like seeing the benefit of it. But there's some surgeons that like that quite a lot. And then there's something called the next frame. It's a variation on these others. I think it has some advantages and disadvantages. So let's go through the surgery a little bit, and I'll walk through this part. So the most important parts of the DBS surgery actually start outside of the OR. So the most important thing is probably patient selection. So what the biggest thing that decides whether the patient does well or not well is whether they're the right patient, that they have the right disease. Is it sufficiently severe that that it makes sense to do surgery? Is it chronic? Is it something that they are dealing with every day? And have you tried the medications? There's never a time really when you want to do surgery without having gone through all of the medications and having been seen by a very good neurologist who can make those adjustments. There are many times when someone with appropriate adjustments can really be made better just with medication, and you don't need surgery. And so we wait until it really is necessary. This is something of the flow process that we have. So we have, we are partnered with many sort of primary community neurologists. At our own center, we have Peter Hedera and Victoria Holliday, who are very expert movement disorders neurologists that really do a phenomenal job. And so often we have patients sent they have a good neurologist in the community. They come to see our center. They, first see, okay, can we make some of those medication adjustments? These guys are so experienced, they can sometimes really get benefit when other neurologists couldn't. If they feel like the patient might be a surgical candidate, it's severe enough, it's been around a while, the medications aren't working, then we go through a sort of this workup. We have you see a neuropsychologist to test. There are other effects of Parkinson's disease on memory, on cognition, on emotion, and we make sure that we are aware of those. We do a standard testing called the UPDRS scale. Has people been through that? Coming on and off your medication and being tested for your rigidity and your walking and all that. So usually there's a measurement and a score that is done as people are considering surgery to kind of quantify how bad is the Parkinson's disease, how much is it helped by medication, how much might we help it with our surgery. And then when all of that is done, we have a multidisciplinary conference. So we all sit down together and talk about the case. We sometimes review videos, we review all of these different testing, look at MRIs, et cetera, and come to a consensus decision on, hey, this we think would be helpful, or no, we don't think now is the time for surgery. And that I think is the key process. And pretty much every center, I think, nationally that does a lot of this has a process very much like that is comprehensive, because if we are much smarter as a group than any one of us is alone. And we often, after conversation, even though I maybe come in with some idea about what we should do, my mind is often changed when I have the opportunity to look at it and discuss it with Dr. Hedera and with my partner, Dr. Zamar, and others. So then you're stuck seeing the neurosurgeon, which, no one likes that part, but a necessary part to do the surgery. We do the surgery. We do programming usually occurs over the several months after surgery. And then ideally we get you back to your primary neurologist. A lot of the neurologists in the community are very good at following patients and making the small adjustments that you need. And we think that's sort of a comprehensive way of treating patients and working with them broadly. Here's a picture of the conference. This is actually the conference that we had at Vanderbilt. It's you can see it's a relatively large group, and we're very serious. That's important. So you can see how serious the people are there. I mean, these are good. I really enjoy this conference, and I find it very useful in making decisions. Okay, and then so let's get to the surgery itself. So how do you do the surgery? There are essentially 3 stages of the surgery, the way that I do it, and so I'll describe that, and I'm happy to answer questions. I have done this a half dozen different ways, and I can speak to any of the other frames or anything that you're curious about. So the way we do it, we start by putting in these screws, these bone markers, and what they do essentially, they do 2 things. They are going to be the attachment point for the frame that we use, so that when we're doing the surgery, it's rigid. It really is stuck to the head in a way that's going to be very precise. It also creates a reference point. So in order to do stereotaxis properly, I need to have points that I can identify in 3-dimensional space, and a relationship on the CT or MRI of where those points are in relation to the target that I can identify and want to treat. And so this first step, we put these screws in that can be done under local or can be done asleep. We put a couple of staples or stitches on top of them. They go under the skin, so you can see at the end, the screws aren't sticking out. They're very small. They're just a few millimeters. And then usually that afternoon, I will sit down and do the plan. So I have software that looks like this that lets me. And again, I'm sorry these images didn't show up well on here. It looks more sensible. But I can see the targets. I can identify them. I'll show you some of the very refined techniques that we do use to more perfectly identify those targets. And I tell the computer, hey, I would like to make a frame that looks like this, that attaches to these screws, that has two rings here that will attach to the little robotic drive that we use, and that's going to get me the safest trajectory to both STNs or the target that we're looking at. I send that off to the company that makes this, and they use this as a industrial 3D printer that basically prints that out in three-dimensional space, and they send this to me in the mail, and that takes a couple days. So usually we do this about 5 days. We usually put the screws in on Thursday, and we do the surgery the next Wednesday. So 6 days between the two. And these frames have been tested. They are tremendously precise to within a fraction of a millimeter. So they are very, very precise, and they are more comfortable. So I think there's some significant advantages to that. And so the big step 2 is the main surgery. We're putting the electrodes in the brain. And again, this is where the question comes up. Do we want to do this awake or do we want to do it asleep? I think there are advantages to doing it with patients awake. Here you can see a patient who is in the operating room. The electrodes are actually in the brain. That frame you can sort of see here is attached. And this was, we were doing an experiment in this case where we would have them wear goggles, and we are sometimes doing studies to understand how the brain works. So we will take a few minutes out of the surgery. We will have them play essentially a video game where they press buttons. They can see that on the goggles or on a screen, and we understand a little bit better what is the basal ganglia doing, how is it working, and so that's something that we have done. That aside, patients are awake, they can talk to us. I tell patients the one advantage of being awake is that you can tell me if you are uncomfortable or anxious or unhappy for any reason. Please, I'm right there. Take that time and tell me. We can absolutely get you through this comfortably. There's no reason people should be uncomfortable during the surgery. The complaint I get most often is just that it's long. So people are sitting several hours, their neck gets stiff more than anything. I rarely get any complaint about gee, this thing hurts my head, or and the drilling can be a little noisy. Usually people are sleepy enough during that part that they don't hear it, but sometimes they hear it, and that can be a little. I will prepare patients and say, okay, it's going to be a little noisy for a minute. You'll feel some vibration. It won't hurt at all because the bone, you don't feel that at all. So the next thing we do is to actually listen to cells in the brain, and so we have electrodes, and we usually have these multiple little mini electrodes that we put in to map the area. So if we're aiming, this is a map of the STN. This is the STN here, the thalamus above it. And I don't think my audio plays on this. So people are fond of playing these. I can play them later if people want to hear it. The different parts of the brain have cells that fire in different patterns, and we can hear that difference. So we spend some time in the operating room listening to cells and hearing when we get areas that are more noisy or areas that respond. There are absolutely some areas where you move your hand and that cell fires all of a sudden, and so we know that is linked to movement, and that is a good sign that we're in the right area. With tremor, there are some areas that will have a tremor cell, so you sometimes get to a cell and you hear it go whoosh 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 like that, and you can see that it's linked to movement, and that's exciting. That helps us know that we're in the right spot. After that, again, we do this thing where we stimulate and we see whether the tremor actually goes away. So here you can see a patient. This is a patient we had in the operating room. This is Dr. David Charles. Oh, the video again is, maybe could we turn the lights off in back? It's worth seeing this part. Thank you so much. So this is the standard testing we do. So this is Dr. David Charles. He's one of the neurologists. Our neurologist, Peter Hedera, will often be in the room. Thank you. And so here you can see, so this is in the operating room. We've done much of the surgery, and we're just testing to find the right spot. And you'll see the patient still has tremor. We haven't turned it on yet. So here's that hand tremor that we're trying to treat. And then here it is after we've treated it. So you'll see here on the right side here, tremor on this side, and hopefully here we'll see the other side. Oh, it's the same video. Wait a second. It looks like the same video. Oh, that's strange. Okay. I've relinked these videos and I must have linked it to the wrong one, so I apologize. So in any event, and I will be happy to show this to people because we really do get this effect. Usually when you turn it on, if you find the right spot, the tremor just goes away, and it's exciting. I've had patients tear up in the operating room. It's really exceptional. For some patients who have a mild tremor, which often occurs with Parkinson's, we have to do something to draw that tremor out. So we'll take a laser pointer and I'll have them point at a target on the wall 10 feet away. And at the end, they get that thing so it is sitting right on the target and it won't move. And I often say to myself, I'm not sure I can hit it that precisely. It really works beautifully. Yeah, the last step. So usually that's the end of that day. We keep patients overnight after putting those electrodes in the brain. We watch them. We get a CAT scan. And we will send them home. And then usually about a week later, we have them come back in after they've had a little bit of time to rest and heal. And we put in the extension wires and the battery. They run something like this. And here you can see, this is one of several brands now that makes these, but you can see these are the size of the batteries there. It's about the size of a big pocket watch or so. I tend to place mine underneath the pectoral muscle if it's not a rechargeable, and that makes it even more inconspicuous. People see a little swelling here, but they don't see the battery sticking out. I think that's a nice thing. That surgery takes about an hour, and it's done as an outpatient, so patients go home the same day typically. The newer devices have this nice feature that the leads themselves are directional. So however much time you spend in the operating room kind of getting this precise, you still have the ability to adjust them afterward. And so you've always been able to adjust which of the usually 4 contacts you have, sort of the older leads were 1 at the bottom, 1, 2, 3, 4. These newer ones have these ones in the middle divided into panels. So if you find that you are getting side effects, so it's not uncommon to have a little bit of muscle contraction if you are stimulating laterally, then we can direct that stimulation away from that medially and get a better effect without the side effects. And so we've used these now pretty much exclusively. All 3 companies make these directional leads. And that's it for the surgery. Do people have questions about that? That's usually the big stuff. Yeah. Yeah. So yeah, it's a good question. So robotics are used in a couple ways, and I think the term is used somewhat loosely. When we watch Star Wars, we all think of to ourselves of robots that are coming in and doing it automatically and making snappy remarks or beeping or whatever it is. We really don't have anything in surgery that is robotic in that sense. What we have are things that are essentially motor assisted. So if you look at that frame that you saw here, that was kind of a big arm. All that really is, the stereotactic frames have coordinates. If you're going to target the STN, you have to dial it to 123/27/41, whatever the coordinate is. And that can be done manually, where you sort of slide this thing and move it over, or it can be done with a robot where you punch that into the computer and it moves. So that is one kind of robot. The device we use is something in the middle. What it is we dial those coordinates into the shape of the frame itself. So it is printed in 3 dimensions by a robot, essentially that prints it in plastic. And when we put it on the head, it is already aimed right for where we want it to be. The way we move the electrode into the head is that we have 2 techniques. One is we have a little crank that we just turn it, so it's done very precisely. You can dial it, you can as much as 1/10 of a millimeter to advance it. And sometimes we hook that up to the computer and we advance it robotically, but in essence, it's the same thing. It's not It's not Star Wars yet, I guess. But yeah, that's a good question. Um, I'm gonna, because I realize I'm running late. I'm gonna try to maybe run through some of the more interesting stuff. So let me talk about this. So there have been, so does this work? I've told you wonderful things about surgery and the history of it. Does this actually work? So there have been now pretty close to 10 studies that actually randomized patients, where you had patients that had the implant, and then we did a period where we didn't turn it on for a while, and we saw how patients did. And what you see pretty reliably, the best measure of this, we think, is called the UPDRS scale, the United Parkinson's Disease Rating Scale, that measures your tremor and your walking and your stiffness. And what we find is that in every one of these studies, the baseline is a very high score, 40s and 50s, in a group of patients that's been as high as about 250 per study. Um, if you turn it on, you get a pretty substantial reduction down into the 20s, and each study had a little bit different number, but all in the same range, about a 50% reduction in that UPDRS scale with stimulation, and that is sustained. These studies were for a year; those studies were for up to 5 years, and that effect persists. Anecdotally, I've had patients who had this placed 20 years ago, and they still are getting, many of them still getting a wonderful effect, and it's pretty remarkable to see them. You come in, you sometimes will turn it on or off to just test to see how they're doing, and instantly the tremor comes back. We turn it on. The tremor does progress, or the disease does progress, but the stimulation is still able to give that symptomatic relief. And so I've had patients who still look great when it's on. They turn it off, and I say, "Gee, that's my tremor was never that bad before I got this. It's progressed underneath the stimulation in essence." Um, Yeah, so you're able to adjust it as you go along. You're able to dial it up. Most patients, we used to think that we were going to be dialing it up, a little bit every year. What we found is that that's rarely the case. Usually, if you find that right level of stimulation, it seems to work without much adjustment year to year, even 5 years out. But some patients do need periodic adjustments, and some patients do lose efficacy, and they come back and we say, okay, well, what shall we do now? This didn't, the experience, I would like to say that every one of my patients has a perfect response. And of course, like every surgeon, that's not always true. I have some patients that have a fantastic response. I have some that have some benefit, but not perfect. A few patients, very rarely, where we just don't think it helped, and we have to kind of go back to the drawing board. That's pretty rare, but a few percent maybe that do have that. And some patients, you make an adjustment, you pick a different target, or you add an electrode, and that is enough to make the difference. I'll touch on this really briefly. So it's not just that this scale is something that people talk about, but it's not clearly the same. The other thing that I think is very important, more of the recent studies have looked at quality of life. They have like standard quality of life questionnaires, and they've asked people, okay, are you better? What do you do with your day? Are you able to go back to work? Are you able to do your hobbies? And on all of those scales, the improvement is substantial. It makes a huge difference. And so that is maybe even more important than this sort of arbitrary measure of how much tremor and stiffness do you have. I'll jump to this because I think this is interesting. So have people heard about these different targets, GPI versus STN? Has anyone had conversations around that? So there are two targets in Parkinson's disease. And if you remember that wiring diagram we had at the beginning, there's one little target, the STN, which is a kind of one of the areas that's upregulated. GPI is a little bit larger target. The surgeons at the University of Florida had someone make this cartoon because there was a time when this was sort of hotly debated, which different centers were using different targets and which one would be better. And so there was this battle between the two targets. What they found ultimately was that for the most part, they do the same thing. So the efficacy of both targets is about the same, and it makes it a little bit hard to decide. There have been in various studies some subtle differences that favor one or the other. So when we have patients that have a very high medication dose going in, STN seems to be a little bit better at reducing it. If you have more cognitive problems, verbal fluency, the difficulty finding a word on the tip of your tongue, some depression that comes along with the Parkinson's disease, difficulty with your gait, all of those things can be worsened by the STN. And so the GPI may be safer. And so different centers we will usually debate this in that conference that we talk about which target is better for this patient, and we try to tailor it. Yeah. Not as much. So I will touch a little bit. So I do. Does anyone here have a central tremor? Is that something? Oh, so you're here for central tremor. Okay, good. So I included that in this talk. I wasn't sure whether I'd be talking more about Parkinson's disease. Great. Okay. I'll keep that. I won't gloss too much over it. So I'll talk about essential tremor. Okay. Okay, so some do. I mean, it's not. There have been studies looking to see how often that is done. The majority of patients don't need that, but some do need adjustments, and it's nice because you can do that, especially with the newer directional leads. It really is beneficial to be able to not just the amount of stimulation, but where you direct that stimulation, which is nice. The target for tremor is typically something called the VIM thalamus. And so I will talk a little bit about that and some of the things related to that. It is sometimes used in Parkinson's disease too. When you have a Parkinson's patient who has mostly tremor, we will sometimes think about that thalamic target. It is in some ways a cleaner target. It doesn't have some of these side effects. It tends to affect tremor very well, but not really touch on much else. And so that is sometimes preferred. As far as tremor, you can get tremor control in both of these targets. People argue about which one is better. I put question marks here. I don't think we know. I don't think it's been well demonstrated nationally. Questions about Parkinson's disease? Let me go through essential tremor and talk about that. So essential tremor was actually the first target that was used for deep brain stimulation. Dr. Benabid, that was actually a tremor patient where he first identified this. And it's an interesting disease. It is about 10 times more prevalent than Parkinson's disease, yet we do fewer cases. So there are a lot of patients with tremor out in the community that simply don't get help. And we wonder why that is. Some people think, it is often familial. So there's often someone in the family, a parent, an uncle who has had tremor. And so people sort of maybe have the expectation that, well, that's just what happens when you get older. And so they don't seek treatment. I've had one patient I know that went to their primary care doctor and was told, well, you just have to live with that. There are people with cancer and other terrible diseases. You should just, and so she had the good sense to go and find another doctor who sent her to us, and we were able to help her quite well. But it's a common disease that can be treated. And I'll jump to some of the more interesting stuff about it. So here, there is a related network. I showed you the basal ganglia wiring diagram. Now that you all have memorized that other diagram, here's another one for you to memorize. It's similar. It involves some targets in the cerebellum and red nucleus, but the end effect is that it produces the same kind of a washing machine vibration oscillation in the thalamus, and we think that is probably the best target to capture it. Here are some examples. So one of the common tests that we do to sort of identify tremor is something called an Archimedes spiral. So you have patients draw circles like this. Here's a patient before surgery. This is actually pretty mild. This is not a bad Archimedes spiral. Maybe not even one that we would consider surgery for. Many of my patients before surgery, they can't even keep the pen on the paper, and it's a very challenging thing. We'll see if this video plays. I've had some trouble with my videos. So here's a patient that we implanted many years ago. You can see she had a very bad, very wide, broad tremor. And you'll see she's going to turn herself on. This is a time when we used to have two batteries. We would put one on each side. For the most part today, we run it all to one battery. The systems allow for that pretty well. And you can see tremor is lovely because it works usually so well. You can get very, very nice control, and it can be almost complete. People describe sort of a 90% improvement in tremor. Some people will still notice a little bit of a vibration, but usually it's substantially improved. There are alternative targets, and there are some patients in whom the tremor is hard to control. And so we sometimes think about different other areas where we can stimulate, something called the posterior subthalamic area or the VOP nucleus. etc. And you can see this is one of those targets on a map of the brain. Usually not necessary, but something that has been described and considered, especially for more challenging tremors. Yeah, there are other ways to do these things non-invasively. So one technique that has been tried and that we had a trial of was something called gamma knife or radiosurgery. This is a technique, it's analogous to those early surgeries where we would put a probe in and burn a few cells in the brain. We sometimes do that today for patients that for whatever reason don't want the wires and the battery and all that. But usually we reserve these, to not do this with surgery, but to do it with radiation. We do that in patients who, for whatever reason, they are very sick. They have bad cardiac disease. They have other risk factors that we think they would not do well with surgery. And so we can sometimes recommend this therapy. The good part of that is that it does tend to work, but it is probably less complete. It gets you about a 70% chance of improvement, not the 90% that we expect with the main surgery. And this is a series of studies on that, all showing that patients do improve with gamma knife. A related therapy, which has come about just in the last 5 years or so, is something called focused ultrasound. Have people read about or heard about that? So focused ultrasound is the same idea. You're going to damage the same little part of the brain in the thalamus. It's the same area that we put the electrodes in. The trick with this is that instead of using radiation or using surgery, what they do is they use ultrasound, and it's a computer essentially that calculates if we were to vibrate the skull from the outside, where would we have to vibrate it in order to guide that ultrasound and heat up a little area of tissue in the center of the brain. And so it's a pretty amazing technique. In practice, it is a little bit better than the radiation because you can do what they call a partial heating. So you can heat it to 45 degrees centigrade, and that's enough to see A, did you get the right spot? And B, do you have any side effects? If patients start to describe tingling or some problem, then we know to redirect it, to re-steer it. And so I think that is the technique that is seeing more and more utilization. In my mind, so we don't have that device here. I have sent patients to centers that have it, and I have friends really all over the country that are doing it. I reserve it for patients who have some good reason not to have surgery. I don't think it is quite as effective as the DBS surgery, and I think most people, even those who are doing this, agree with that assessment. Many of them have said to me, "Gee, I do much more DBS now that patients are coming to me asking for focused ultrasound." It's only a few of them that really probably need that therapy and not the DBS. So I think no conversation about surgery should not have some conversation about complications, because everyone who is thinking about surgery is thinking about this, and I think it's important to acknowledge that, of course, there are complications that can occur. We have to date done, about 300,000 of these surgeries internationally, maybe more. I think it's more than that now. That was the last time I saw the numbers, but it may be 500,000 now. It's escalating. And so we have a pretty broad experience. There are exceptionally large series just describing, how this is done and what the complications are. And this is the sort of the breakdown of it, right? So, and some of these are higher than others. So, for asymptomatic, this seems actually very high to me. I haven't looked at this in a while. So what we usually describe is I guess 3 to 4% in the study of a very small hemorrhage at the tip of the electrode. For that to be symptomatic is about 1%. For that to be, so the worst thing that can happen in surgery, to take a step back, is when you're putting these probes in to have a little bleeding at the tip. And you can imagine how that might happen. We do everything we can to avoid that. And often, and most of the time we can, but occasionally you do see a little bit of bleeding at the tip. Most of the time that's asymptomatic. It doesn't have any effect. It heals on its own. We watch that patient a little bit more carefully. Occasionally, about 1% of patients will have a symptomatic hemorrhage. And you can see that here, 1.1%. So that's about right. I think that's usually not something that's very consequential. So it's symptomatic, it resolves in a few days. For it to be a really terrible hemorrhage, or one that is paralyzing or permanent, is about 1 in 500. And I have seen that in my career twice that I can think of, having done probably close to 1,000 cases. So that's about right. It sometimes happens no matter what you do, and that I think is the major danger that I talk about with patients. There are a host of other complications. So there is wound infection, usually 1 or 2%. There's wire breakage, which is, I'll show you here. These things can, over time, the wires break or become disconnected or some such thing. Again, that's 1 or 2%. So it's, those things can happen. Those things, I always think they are a hassle for the patient, but they're not life-threatening, and so that's less concerning. Even infections, as long as we're on top of it, we can, sometimes just wash it out. In the worst case, we have to explant, remove the system, and come back. But I do have a handful of patients who have had that happen, and we had to take the system out, and then we came back and put it back in, and they do great. The stimulation itself, I'll talk about MRIs also. The stimulation itself can have side effects, and so that's something we're very mindful of. Some of those are the obvious things we can test for in the operating room. They have a little tingling or they have some muscle contraction. We usually hopefully have already avoided that, and often if we haven't, we can fine tune it to avoid that with stimulation, with programming. Occasionally you have some subtle effect, mood effect, where we've had a rare patient become a little bit manic because we're close to emotional centers. It's more common with STN stimulation than with the others. Again, as long as you are on top of it, we can usually correct that with stimulation. Pretty rare for that to be limiting. Something that has been discussed quite a lot is MRI safety. So can you get an MRI with these devices? The answer today is that you can get MRIs, and those MRIs are getting more and more complete. I think several of those systems now are even compatible with the 3 Tesla, with the newer, better MRIs. This was an important issue because there were, in the history of DBS, there were, to my knowledge, 2 patients who were injured because at that time they didn't know that these systems needed to be calibrated, and somehow they had a scan that caused damage. That's 2 out of, we think probably 4,000 patients that had this. So it's an exceptionally rare event. And I think only 1 that was badly injured of that. But today, with the new regulations, as long as the MRI center that you're at knows that you have a system and they're being careful, there's no danger at all. So I'll talk really briefly about some of the innovations that we're using, and then I can take questions for as long as you guys want. That's unreasonable. So I've talked a little bit about the way we target today and some of the techniques we use. We're making that better and better. So 1, the MRIs that we use are exceptionally useful. 2, we are starting to be able with MRI to actually see some of the fibers. And we think a lot of the effect of DBS is an effect on the different fiber pathways that connect these nuclei. So by identifying some of these, this is the corticospinal tract that's very close to some of the nuclei. We can use that in our targeting, and at some centers they are actually using that primarily to identify where they're targeted in some kinds of surgery. The next innovation that I think is really going to be important is something called closed loop technology. So right now, for the most part, these systems only stimulate. They kind of stimulate all the time at the same frequency, and they're in the grand scheme of electrical stimulation. It's kind of dumb stimulation. It's just regular firing. Newer systems, intelligent systems, would be able to sense and stimulate, and only stimulate when you really needed it or in a pattern that might be helpful. We're just beginning to understand. So there have been a series of studies done where they have electrodes in the brain and electrodes on the motor cortex, on the motor part of the brain, to see how these things talk to each other. And so using some of that information, we think that there are different frequencies of stimulation that may work even better than the ones we have today. And we're developing devices that will do that. The first of those devices was this device called the PC Plus S, which is a terrible name. They renamed it something called the Percept. That device exists today, and it's one of the brands that we use. Right now, you can either sense or you can stimulate. It doesn't do that closed loop thing yet, but may do so in the future. Big data is another thing. We have enough patients now that we can actually amalgamate all of the data that we have and try to figure out, are there better targets? Can we correlate patients who had electrodes placed in a particular place with the best effects. And so we were involved in some of that research at Vanderbilt when I was there. I'll show you this very briefly. So we had an algorithm, which I think I could show you here, where we could take each patient's MRI and morph it from the shape of their brain onto the shape of a standard brain. All of our brains, if you look around the room, people's heads are different sizes and slightly different shapes. And those subtle differences can make a huge difference in surgery. I can't always target the same location in the brain because every patient is just a little bit different. So this helped us begin by sort of normalizing what the brain looked like. Once that was normalized, I could essentially go to every voxel in the brain and assign an effect. So I know in this voxel here, if I stimulated 1 milliamp, I get 20% reduction in tremor. This one, I get a 10% reduction. I could start to categorize that. And if you do that for every voxel in the brain, you start to have more meaningful information. At Vanderbilt, we started to do this with our patients. We expanded that to centers across the country. So this is a network of centers that all contributed data to this. And pretty soon we had more than 3,000 patients and something like 60,000 points of information. We put that all into this process, this atlas that we called Cranial Vault, that basically began to make conclusions from all that data. And what we found was that if you actually look at what your target might be, when we took all the targets that people had used, they had shot all of this area was an area where they had tried to stimulate. Yeah, but when you normalize that data, it was pretty clear that where they got efficacy was right at this very little spot. And so we can use that now. So they took one of their surgeons at Vanderbilt, me, and they pitted me against the computer. And what this plot really shows you is that the computer beat me pretty handily. So this is sort of all of my targeting here, which I thought was pretty good. I had been doing this for a long time. The computer did even better. And it was not only that it was more accurate, it was more precise. It more reliably found those points. We can use that same kind of targeting to identify the best trajectories. So here again, they pitted me against the computer. I thought I was pretty good at finding a trajectory that was safe. The computer was at least as good as me and maybe better. Here was just a comparison of the two. That really the computer was in this case as effective as me. I couldn't tell them apart. I was asked at one point to pick out, okay, which of these did you target and which ones did the computer target, and they looked exactly the same. The other thing that we can do is sort of put biometric data into this same database, so we can look at patients in different spots in the brain. Okay, what was the effect on patients' sleep? There are sleep monitors, there are activity monitors, there are wearable clothing devices. There's sort of this, what people call the Internet of Medical Things is sometimes a term used. We can incorporate all of that into this and see if we can use that to be even more precise about the way we track the effective stimulation. And so that's all work that is ongoing in collaborations between our center and Vanderbilt and many others. And so I'll summarize briefly. So, this is really an old field. So we've been doing DBS surgery or the precursors of that for about 70 years. There's a huge body of evidence, I think, that supports the use of the surgery. And in my experience, having done this for 20 years myself, it's tremendously effective. It has to be done right. And there are complications and there are risks and there are patients in whom it doesn't work perfectly. And it is a process sometimes to get that exactly right. But I think it's right now very effective, and with innovations, it's only getting better, and I'm excited to sort of see where it goes. So with that, I can take questions, and I might just actually sit down and talk to you guys for as long as you're willing to listen. Thank you. Yeah. Was that helpful to people? Was that too much detail? Not enough detail? Was that? No, you don't have to applaud. I'm not asking for that. But other things that people wanted to hear about? I was thinking about what to talk about, and I have a bunch of talks that I've given in different venues, and I usually will use some of the slides. I picked slides from a talk that I give to other surgeons because I thought this crowd might be interested in that, and I changed some things and included some other stuff. But I think it's sometimes more interesting than the standard slides that are shown to patients are less detailed. And so
that ultrasound that's amazing.
It's a pretty amazing technique. I completely agree with that.
I mean, that was pretty incredible that even exists. I didn't even know that existed.
Sure. No, I agree. Other questions?
Anybody at home?
Yeah. So that's a good question. So again, what we think about those kind of criteria, let's talk about Parkinson's disease first, perhaps. Parkinson's disease. Maybe I have feedback in this. I'm going to take this out for a second while I answer questions because I'm hearing myself.
You know what? Actually, no, I'm muting myself because I'm in the room. Okay. So if you want to agree, please, you could. Okay.
You guys hear me better now? Yeah. I think I hear. Okay, good. So Parkinson's disease, there are a number of reasons why patients will benefit from it. Usually, when you first are diagnosed, medication works really well. People who go in and sort of have just started to have symptoms, the first time they try levodopa, it's remarkable. They suddenly are much looser. It kind of restores them very well, and we think that's because they've just crossed this threshold. They've been losing dopamine cells, as we all do in our lives. But they're losing cells, and they get to a point where suddenly they're tipped over that edge, and they start to have the tremor. They start to have the stiffness. At first, the medication is a little bit is enough to take care of it. It lasts a long time. You take it in the morning, it might last you 6 hours. You take another one in the afternoon, and that's really all you need. And we don't recommend it in those patients. As the process continues, for the most part, people tend to see they're having to take the medication more often. They start to have fluctuations that at first are predictable and then become unpredictable. So you take the medication, it might last you an hour, it might last you 6 hours. You just don't know. That's usually where we start to think about the surgery. The other phenomenon that tends to occur is they start to have flexible responses to the medication. So they have dyskinesia. So they start to have movement. If you've ever seen in Michael J. Fox, it tends to be very obvious if you can remember when he was on Larry King or something like that, he would, I think, correctly take the medication right before going on stage because he needed to be mobile. He needed to be able to answer questions and talk, but invariably it made him too mobile. So he'd kind of be doing this and moving. And that is the kind of the flip side of the medication. It's this range between too little movement and too much movement. And so when we start to see that is sometimes a time when the stability of the stimulation, just being a regular 24-hour stimulation, is beneficial. So those are the major reasons. There are some patients who have Parkinson's disease. They respond wonderfully to medication, but it doesn't control their tremor, where tremor is a piece that just the medication doesn't affect and stimulation can. So some patients will have, so non-responsive tremor is a reason to have it also. Those are the major considerations. I think that's kind of Yeah, okay, good question. So does DBS control speech and gait is the question. So that is a little bit of a tough question to answer. And the best way to answer it is there are elements of speech and gait that can improve with stimulation. They are typically the same elements that improve with medication. So if a patient finds that they take their medication and for a few hours they're able to walk more easily because they're not as stiff, they can get up from a chair and walk across the room, and their speech, maybe their volume comes up a little bit when they're on their medication. Stimulation will do those same things. At the same time, there is an aspect of Parkinson's disease that creates things that we can't treat. So patients who have gait problems, because of balance. When they try to walk, they are a little bit unstable. Stimulation does not help that the same way medication doesn't help that. And occasionally in the SDN, it may make it a little bit worse. The same for speech. If you're having trouble finding a word, if you're like, I just can't get that word off the tip of my tongue. Sometimes hypophonia is a tough one. If you talk very quietly like this, it probably is not the best thing for that. SDN again has been known to make that worse in some patients. Some of the loud therapy, there are sort of occupational therapy techniques for improving speech that are quite effective. Yeah, question.
One of my main reasons for being here is appropriate situation that I'm in. Anytime I turn it on,
Mm-hmm.
whatever control that I have causes me to be unable to walk.
Okay.
My right side is not functioning when I'm able to control my right hand.
Got it. Sure. Is it stiff when you turn it on? Do you have stiffness on the right side? Does the okay. Okay. Okay, and that stays. You still feel the tingling even when it's been on for 10 minutes? Yeah, okay. All right. So that effect, so do you mind if I repeat for the people in the audience, the virtual audience? A gentleman in the audience is saying that he has a stimulator that when it's turned on, it improves the tremor, but it also causes tingling all over that same side of the body. That is a common, so almost every patient with a thalamic stimulator will have some of that. It is usually transient. We sort of know that we get the best effect when we are close to those sensory fibers. But part of the trick is being close and not in them, and that's one of the reasons that we like to do this awake is we test that often in the operating room. There are times when when it's for whatever reason it's different after being in the operating room somehow. The best strategy for dealing with that immediately, it looks like you have an Abbott system, is that correct? Okay. That's a directional system. So have they tried steering it on the anterior contact?
At first, I didn't have that.
Okay. Okay.
It's a hurt.
Yeah. Got it.
How,
Yeah. Mm-hmm. Sure. Yeah. Yeah. Okay. So when did you get the system implanted? Yeah. Well, how long ago was it? Okay. Now that would have been the newer system. That's Infinity system. Is that what the name of the? Why don't we talk after that, and I'd be happy to give you my thoughts. Yeah. No. I'd be happy to sit down with you as long as you want. Well, I mean, we can talk today. But my first thought is adjustment may be helpful if they've tried that and they've been reliable about it. Sometimes you have to reposition the electrode. That happens occasionally. Sure. Okay. Absolutely. Other questions?
I have a question.
Yeah. Virtual audience.
I have essential tremors, and mainly my tremors in my head, and I have a voice tremor. But they
Yes.
told me DBS wouldn't help for the head tremor.
Okay. All right. So I'm going to repeat the question just so that people here in the room can hear it. So this is a woman in the audience who has essential tremor, has primarily a head and voice tremor, and has been told that that is not well treated with DBS. So it can be treated. It is less reliable. The DBS works best for what we call an appendicular tremor in your hands, tremor, et cetera. At the same time, a lot of patients will have a head and voice tremor. Usually patients will have both. They have the hand and the head tremor. Those, what we call midline tremors, tremors of the voice, tremors of the head, can also be helped. They are helped to some degree by having a single electrode. They are helped more by having bilateral electrodes. And there was a recent study that was done that actually looked explicitly at this very phenomenon, but it does help. It is not as reliable. You sort of, if you expect 90% chance of improvement with hand tremor, the expectation would be 60-70% chance of improvement with that head tremor. But we do it all the time, and we have had good effect doing it, and I think you can get that effect.
Erica.
Are you guys able to hear Erica? Why don't I can take this out and maybe we can just hear that we can let the iPad talk to us. Would that be better? That way everyone can hear those questions.
Can you all hear me? Yeah? Okay. Well, I don't know if you all heard what I just said or not, but that is also my diagnosis. I have a head and voice tremor, and I see Dr. Neimat, and I'm going through the DBS, what do you call it? Evaluation. And we're considering it, and I'm definitely in the decision process, but yeah, so it is 60-70%, but we're definitely considering it, and that is definitely where I'm at, and we'll see how it goes. So yes, it is possible.
Yeah, no, I usually am pretty enthusiastic about it.
Yeah.
I've just seen it work very nicely.
Absolutely.
Other questions? Yeah.
Anybody?
You mentioned that essential tremors. Is there any movement
Yeah, so there's been a lot of research into this. There are a handful of genes that have been identified, families where it's sort of concentrated. Parkin being one. I think there's a handful of specific genes. For the most part, the majority of Parkinsonism is not. No one knows. Other questions?
What about stiffness? Does it? I'm real stiff. This muscle.
Yeah.
And this muscle from here to here. I don't know if DBS is a potential solution.
Yeah. No. Absolutely. So the cardinal symptoms of Parkinson's should be stiffness, bradykinesia, which is that difficulty kind of getting up and starting movement, and tremor being the third. It works really well for those symptoms. Some stiffness, people have sort of cramping in their feet. That may be an actual dystonia that occurs sometimes. It's contracting of muscle, and that happens often in Parkinson's patients on medication. It can work very nicely.
Thank you.
Have that too.
Yeah.
All right.
And these, they are sort of intertwined. I think they all of these degrees, we sort of have these distinct names from the parties, central memory, Estonia, but that they are related dysfunctions of this network of nuclei in the brain. So that every part of the patient is a little different, every patient can be a little different. So part of the nuance of these surgeries is having a team that kind of figures it out and make an educated decision about what is the best spot to stimulate and how best to.
Does insurance cover any of this?
Yeah, no, it should cover all.
Oh,
Whatever you're hoping. Like any surgery now, it is so well established. There are very few things in neurosurgery that have, a half dozen randomized controlled trials. So it has now been there are guidelines for using this. Used to be they would object, and we would have to have peer-to-peer conversations to convince them. These days it's so well established. Covered all up.
Oh, good.
It should.
Good. No,
Well, I'm happy, I'll be around for as long as people want. If anyone wants to come up and ask me a question. And, for those in the audience, if you may be seeing some of our neurologists, if not, please give us a call. We are always happy. Happy over there that just joined us from Vanderbilt. 2 years, but he still has some space in his clinic and hold people. That's been a challenge in the past, and we're very hopeful.
thank you.
And I know everybody here got a flyer, but our next meeting is March 5th. It's going to be a great meeting. We have a local company called Stretch Zone coming.
Yeah,
wanna talk more about that?
Yeah, you guys have get this flyer in email too, and we've also started creating some QR codes for Zoom or for Facebook or for whatever. But it's gonna be Stretch Zone.
Put your camera over.
Yeah, and so if you guys haven't ever used a QR code, it's simple. Just open up your camera and you just point it at it. You don't have to take a picture or anything. It just pops up. You just hit the website and it just takes you automatically there. It's just like clicking a link. But yeah, Stretch Zone. Eric and I had actually tried it out, and that's why we reached out to them because it's almost like massage, but they're just physically stretching you. And so, as you can imagine, there's lots of benefits to that for flexibility. Yes, and yeah, I needed it a lot more than what I thought I needed. Yeah,
I was curious.
yeah, it's actually really good.
Is it an interactive meeting?
Yes.
Yes, there will be an interactive.
Yeah, try to comfortably. Yeah.
Yeah,
It's going to
Yeah,
be
so-
awesome.
if you're able to come in person,
Very interactive.
you can
Or on
be physically
Zoom.
stretched, on Zoom. But then also, I know that they will be offering everybody a free stretch whenever you would like to go.
I didn't know that.
Yeah.
Okay.
Well, yeah. If you mention that, they, this will be after, of course. But if you mention that you were in the group or mention Erica or I's name, they'll give you your first stretch for free. So.
Did you get anybody's email? Still?
Oh, yes. Also, if you are not on the email list, and if say this is your first time here, if you can put in the chat feature, if you can write your email, so then
We already have it. Don't worry about it.
Yeah.
But if you are new to our group,
Mhm. That way you can get added
Please
to
put your
the
email in.
newsletter list, so you can start getting all the information.
thank you.
All right.
And we will update everybody of anything new going on. Thank you
Thank you,
guys.
See you guys. Have a
Bye.
great day. Thanks for joining us from Australia as always. You're a trooper.
I'm gonna stop there.
How many people were on Zoom?
We have